Besides the CTLA-4 inhibitors, tremelimumab and ipilimumab, which are already in combination, I think I'd keep an eye on things such as TIM3 and LAG3, two other checkpoint inhibitors that are involved. I think those are in more advanced trials right now. Agents, that are agonists for T cells, such as 4-1BB, CD137, are looking quite exciting. There's a whole host of what we call bifunctional antibodies, which might bind tumor cells and also bring in immune infiltrate by binding CD3, for example. Some of those are in clinical trial. There's an enzyme known as IDO, which is involved in immune regulation, and there are several inhibitors of IDO inhibitors, because it's been shown that blocking that, might activate the immune response in a more profound way. So those are just several of the agents that are in trial right now. Other agents that might stimulate immune infiltration as well.
In the setting of frontline chemotherapy, combinations of checkpoint inhibitors with chemotherapy are being investigated actively. The IMpower studies are a series of clinical trials combining platinum-based chemotherapy with atezolizumab versus the standard of care chemotherapy. These studies have not been reported yet. They were designed on the basis of very encouraging objective response rate in smaller phase 1/2 studies reported a couple of years ago.
There are a number of clinical trials now that are comparing IO combinations to standard chemotherapy in the frontline setting. Checkmate 227 is an example combining nivolumab with ipilimumab versus standard chemotherapy. That trial has not yet been reported, so we've not seen any of the results, but the early phase 1 and phase 2 data certainly look promising, with response rates that appear to be considerably higher than nivo alone. The big question, however, is the nature of the patients going on these trials. Will we see a preferential benefit for those with higher levels of PD-L1 expression? And the early phase 1 data did suggest that. So I worry that these broader trials that take all comers independent of PD-L1 level, we may ultimately dilute that benefit, that we really have to look at 3 separate groups, 50% or higher, 1 to 49%, and those with that expression. I am not convinced or clear if Checkmate 227 has actually captured those very specific data. It would be of tremendous interest to delve into the data once they're presented and see if there is a differential benefit based on PD-L1 level. A separate but very similar trial, Mystic, is looking at a similar PD-L1 CTLA-4 combination, in this case durvalumab and tremelimumab in combination versus standard of care frontline chemotherapy. Again, there are phase 1 and phase 2 data to suggest that the combination can generate response rates certainly higher than PD-1 inhibition alone, with acceptable levels of toxicity. But the proof is in the pudding. We need to see the phase 3 data, and frankly, in this setting, we need to see a survival advantage, as we've seen in Keynote 024 for single-agent pembrolizumab compared to chemotherapy alone.